All right, guys, today is our week 7 call. So we have one more call after this. I know it's kind of gone by pretty quickly, but today we're going to go over filler. So it is a little bit of a longer call. That's just because I kind of recap a lot of things. And so I do try to move quickly through it, but it's not going to be like our normal 20-minute call. It does tend to be a little bit longer, but feel free to ask any questions that you want. Okay. So real quick, I just want to make sure that everyone on the call has everyone has done your launch party, correct? Yes. Tammy, have you already done your launch party?
Yes, I have.
Okay. And how did it go?
Good.
Excellent. Who is
I've-
your you got
Lauren.
4?
Lauren, I did. I've actually done 10 people now.
Excellent.
Maybe yes.
Very, very good. And then Morgan, I believe the last time we had our call, you were scheduling yours or about to have it. Is that correct?
Yeah, I did mine, and then I have a Botox pop-up event scheduled for December 7th with a local facial place here in Houston.
Excellent. Sounds like y'all are rocking and rolling. That's awesome. All right, let's get going. So today we're going to go over some filler stuff. I'm just going to have basic questions over MFL operations. If there's anything that you want to talk about, now will be the time. Same thing for aesthetic record, and then we'll go into our homework. Okay, let's go into our filler recap. This picture is a before and after of one of our injectors. We just did half a syringe of filler on one side and half on the other. So really just want to show you what half a syringe of mid-face filler can do. It made a pretty profound change in the patient. In her nasolabial fold, but also just in the mid-face in general, she just looks younger. So really, when you get into start doing filler after your probationary period and after you take a second filler training, you're going to really start to kind of notice how just really a little bit of filler really can make a pretty profound difference. So let's go into, is that what I wanted? There we go. That's not what I wanted either. Why is it taking me to this? Okay, hold one sec. Let me pull it back up a different way. There we go. All right, can you all see my screen? Right. Okay, let's do a quick recap on filler. Okay, so remember back at filler training, we kind of talked about the different types of dermal fillers. The ones that you're going to be dealing with primarily are going to be the hyaluronic acid fillers. They are going to come in either 1 or 1.2 ml syringes. Whenever you open the package, it does come with 2 needles. One, it's just in case you accidentally drop one, but also if you're doing multiple sticks, they give you another one because the needle does get dull. So we will be providing you, obviously, with all the needles and stuff you use. If you do want to use a cannula, you can order those as well. It is important to know when you first start using fillers, find 3 fillers that you like and stick with those for a little bit, because when you start looking at all the different fillers that are on the market, it can be pretty overwhelming. So where I kind of want you to kind of live for a little bit is I want you to, whenever you do cheeks, I want you to think of 2 fillers, at least initially. You can always branch out and add more. But for cheeks, I want you to concentrate on Restylane Lift only if they are a younger patient, like in their 30s and 40s. If they're in their 50s or 60s, I want you to really live with RH4. So, and that's just because when you think about the G prime in the Restylane Lift is really, really high. It's kind of like putting cement into somebody's face. Someone who's in their late 50s, their skin does tend to get very thin. And so if you put something that's really thick into their face, it's going to look like rocks. That RH4 has a little bit less of a G prime. And so it just gives a more rounder appearance. But someone who's in their 20s and 30s, they can really handle all of that G prime, and it gives them a lot of beautiful projection. So for cheeks, I want y'all to live with Restylane Lift or RH4 and just live there for a little bit. Has everyone used or at least seen those products? Y'all kind of played with them in training? Okay, excellent. For lips, I want y'all to live with either Restylane Kiss. RH3 is really pretty. And Redensity is really pretty as well. So kind of live with those. They really do kind of give you a good baseline product. Stick with those for a little bit and see how you like the feel of those syringes. And then when you start to kind of do more and more, you can start adding additional fillers that you kind of want to play with just to kind of see which syringe you like better. But initially, stick with those. For nasolabial folds, RH4 is nice, and Define is really pretty in the nasolabial folds. It's a really, really nice product there. If you do start doing chins, I would stick to Define in the chins, and it gives you a lot of good oomph in the chins. And then for tear troughs, when you do start doing tear troughs, regular Resty is really nice there. So regular Restylane. You can also put a little bit of Redensity there too if you want to do some superficial lines as well. So when you first start injecting fillers, just kind of live there. Obviously, when we teach you the kind of 3 primary areas, and that's cheeks, nasolabial fold, and lips. Inject a bunch of those, and then you can start adding, chins and tear troughs and things like that. If you do want to start learning kind of some more advanced things like earlobes and hands and kneecaps and things like that, we can definitely do some videos on those kind of things. You don't necessarily have to be checked off on earlobes or anything like that. You just have to have the basic understanding of how to do it, but it's not something that we're like, okay, this is how you inject an earlobe. But when you do start kind of getting there, just ask, and we can kind of give you some, at least point you in the right direction of some videos and kind of do some verbal training with you over those. Okay, what do fillers do? They put volume back where volume has been lost. Okay, so remember, thinking back to training, the aging process around age 35, we talked about how 50% of your collagen is gone at the age of 35. You start losing volume in your mid-face and your lips as well at the age of 35. So derma fillers go back in and they put volume back into where volume has been lost. So these are the 3 different types of fillers. Again, we are only really going to be working with the HA fillers. I am trying to work with the Galderma rep on some Sculptra training. Sculptra is a really great product. It does lay like kind of very small, tiny seeds. And with those seeds over time, help produce your own natural collagen. And so it really is a really pretty product. There is some studies coming out that I found pretty interesting. And it was talking about how patients who've received Sculptra in the past, that they are no longer candidates for facelifts. And I thought that was really interesting because they were saying that the seeds are kind of messing with the different layers of the skin, and it's making it really difficult for plastic surgeons to go and kind of cut through those layers. But we'll see kind of what happens in the future, but kind of nice little tidbit to know. But primarily for you, you're going to be dealing with the HA fillers. They can be dissolved. What is the name of the enzyme that is used to dissolve HA fillers? Very good. I saw Joanna say it. Hylenex. Good job. I saw you mouth it. All right, G prime. G prime is essentially the thickness of the filler. The thicker the filler, the deeper that it can go into the face. So if you have something that has a really, really high G prime, that means it's kind of like cement, like Restylane Lift. It can go right at the periosteum or right at the bone. Where something that has a really low G prime, it needs to be laid more superficially. It doesn't have a lot of oomph, but it can really kind of fill in those more superficial layers of the skin. Is all of this starting to kind of come back to y'all?
Hey, Ann, can you fill in, I'm sorry to interrupt. Can you do that in like a scar?
Yep.
It
Yep.
would be one of the Restylane lifts.
Yeah, you could do it depends on the scar. So if you have like the ice pick scars, like little ice pick acne scars, I would probably do like a Restylane, like regular Restylane would be nice in those. Restylane lift, the only issue with doing that with ice pick scars is that you have to lay it more superficial, or I'm sorry, deeper. And those scars are obviously more superficial, that it will help a little bit, but you really do want to try to get as superficial as possible. So I would probably use like Redensity or something like that there, because you can put that, like see the gray of the needle superficial, and then just slowly kind of build that up over time. That would be a really nice one. Any of the RH products, regular Rusty is good, Define. Lift just has to be laid pretty deep. Otherwise it's going to look like rocks.
Oh, I see.
Yeah.
Thank you.
Yeah, but great question. Okay, these are the layers of the skin. That's kind of like why I like the RH products, is they kind of tell you what layer it needs to go into. Redensity used to be called RH1. They changed the name. Don't know why, but they did. But Restylane Lift needs to be laid in between layer like 5. It really needs to be laid between like 4 and 5. Obviously layer 6 is the bone, so it needs to be laid right at the periosteum. Regular Restylane can be laid in layer 2. Restylane or RH2 obviously would be laid in layer 2. You have the Juvederm products, regular Juvederm, like Juvederm Ultra can be laid in layer 2. Juvederm Ultra Plus would be laid in layer 3. So, I mean, it really is interesting. Wherever you want to put the filler, it will determine which product you want to choose. You would not want to put Restylane Refine, which is a really very superficial product, at the bone, because the G prime won't support it and you would lose the product. So just make sure whenever you are choosing your product that you're putting in the appropriate layer of skin or appropriate layer of the anatomy. Okay, this is the aging process. So right at age 35, that is when the aging process really starts to take an impact on our patients' faces. Those fat pads start to disintegrate and separate. Remember, so that's when the nasolabial fold and those marionette lines start to kind of form, as well as those jowls. That's why it's really important that we start with putting volume back into the mid face. It's not going to 100% correct the nasolabial fold or marionette lines, but it will give them more volume. So then you can go back and do a dedicated syringe in those more concerning areas. Very rarely will I go in and just treat a patient's nasolabial fold. The only time I will do that is if they already have kind of good volume or good structure in the mid face. That's the only time I will do that independently of doing the mid face. Otherwise, they're going to start looking like a chipmunk if you build them up this way. This is your treatment checklist. Make sure that they stop doing any type of NSAIDs a couple of days before, ideally. Obviously, this is not always able to happen, especially if someone just pops into your chair at a Botox party. If they are on aspirin, ideally, you want them to stop it a few days before, as well as vitamin E or any type of fish oil stuff. That's just because it will thin the blood and they have a higher chance of bleeding. It's not going to really mess with anything in the filler. They'll just bruise more. No alcohol 24 hours before. Again, this is very difficult if someone's just trying to kind of plan their procedure the day of or pops into your chair at a Botox party, but ideally 24 hours before. If someone is drinking at a Botox party, they must be clinically sober in order to sign a consent. So you just need to know that. Okay. So just like any consent, any medical consent, the patient must be clinically sober. No vaccines for 6 weeks before or after filler. The reason why we do this is because anytime you introduce any type of like needle or trauma to the face or to the human body, it's going to cause a inflammatory cascade. And if the body is already trying to produce antibodies from a vaccine, you want the body to focus just on that one thing. You don't want to take away from what that vaccine is trying to do. You want to make sure that they get the full effect of whatever vaccine that they had just received. And so you don't want to interfere with that. So that's why we say 6 weeks before or after for filler. No major dental procedures 2 weeks before or after as well. Routine fillings are okay. And then if they have a history of cold sores, even if they have a history when they were 10 years old and they've only broken out one time, still call in Valtrax 2 grams PO BID times 1 day. This is the physical examination. Obviously, you want to take some good pictures. You want to talk to the patient about setting realistic expectations of what they can expect after the filler. You also want to let them know that, hey, I'm putting a needle in your face, because they will always ask me, am I going to bruise? Well, I mean, maybe I'm putting a bruise in your face. You might bruise. You also want to tell them that lumpy and bumpiness is kind of normal and expected up to 2 weeks, especially in the lips. Because you'll get patients, I will always tell my patients, don't love them or hate them for 2 weeks. Okay, because it never fails. There was actually an injector at our last training, and we did her lips, and she was like, I feel like a little, and I was like, nope, 2 weeks. Don't love it or hate it. 2 weeks. And she was like, okay. And she ended up texting me, and she was like, I love them. They're perfect. But so 2 weeks, if they do start to feel a bump after 2 weeks, what I then tell my patients to do is I want them to take it and I want them to slowly massage it twice a day for the next 2 weeks after that. Okay, so now they're 4 weeks post-procedure. That takes care of 99.9% of any lumpy or bumpiness, just having them do that. It's a little bit of them massaging, but the majority of it is just adding additional time because everybody heals differently. If you do have any residual lumpy or bumpiness after that second 2 weeks or 4 weeks out, then that's when you'll go in with some dedicated Hylenex and you'll do and you'll dissolve it at wherever the little bump is. You can dissolve it with 0.1 or 0.2 and it will take care of it. And you go directly into the bump. You don't have to aspirate. Put 0.1 or 0.2 of Hylenex in there in an insulin syringe, and that will knock it out. You always want to talk to your patients about the potential side effects of any time that they're getting any medical procedure. You know, how you talk about a vascular occlusion is really important, because what you don't want to do is you don't want to go to your patient and say, okay, I'm about to do your nasolabial fold, and you know, the risk factors are bleeding, bruising, infection. Oh, and you also might go blind. Like, don't lead with that. Right. So really how you want to talk about a VO is you want to say, okay, you know, potential side effects are bleeding, bruising, infection. And, you know, the worst one is going to be a vascular occlusion. A vascular occlusion occurs whenever a filler is introduced into a vessel and it stops the blood flow. I always carry my crash cart on me so I can immediately resolve if this does happen. So just know that you are in good hands. So you want to tell the patient what potentially happened, but also reassure them that, one, you have the product to dissolve it, but also the know-how to dissolve it as well if something were to happen. So really the biggest thing is educate your patients, but also let them know that you know how to take care of it. And you as an injector need to know that we always have your back as well. You are never an emergency by yourself, ever, ever, ever. One of us can always get to you. And we're also always just a phone call away. So here are the absolute contraindications: blood thinning medications like Coumadin, autoimmune disorders, if they are actively undergoing treatment. Okay, if they're actively undergoing a treatment, I really don't like to do fillers in there. Again, their body is just kind of in like hyperactive mode. And so if they're having a lupus flare up, or, you know, if they're going through something like that, then I'll say, hey, let's wait till this flare up calms down and then we can, you know, reassess. If someone does have an autoimmune disorder, I do stay away from the Vicross products just because I don't want to cause that delayed onset granuloma formation. Active infection, if they have a giant pimple on their face, you do not want to inject directly through the pimple. Obviously, you can cause cellulitis. If they are allergic to lidocaine, lidocaine comes in the majority of the fillers. You can request to get lidocaine-free fillers, but you do need to check with Stephanie to make sure we have them in stock. If we don't, we can order it for you. But if they are allergic to lidocaine, the majority of the fillers that we carry already have it, so they need to have special ones ordered. Allergic to fillers in the past, and then again, if they're pregnant or breastfeeding, those girls don't get to do anything. Safety, you're always going to aspirate. In here it says 15 to 20 seconds. We taught in class 6 Mississippi, right? So make sure you aspirate 6 Mississippi with each thread that you do, or each bolus. Watch for color change, and if they have a history of cold sores, Valtrax 2 grams PO BID times 1 day. These are all the tips for reducing injection risk. You want to inject slowly. Remember, we talked about how the patient's blood pressure is 120/80 on average. If you inject slower than that, it's more difficult to introduce filler into a vessel if you are inside of the vessel. Always aspirate. You want to use HA fillers, something that you can dissolve, and always kind of keep that needle moving, and small little boluses. Never more than 0.1 in the majority of the face, except for the mid face. In that one injection, you can do 0.2. For injection techniques, we talked about retrograde injection, remember? And that is you put the needle in, you're going to aspirate, and as you are pulling out, you are putting filler in a straight line. That is called retrograde injections. You can also do the cross hatching. I do a lot of cross hatching on the nasolabial fold and also in the marionette lines. So how you do a cross hatching is you essentially draw on their face, do 3 lines, do 1, 2, and 3, and then do another 1, 2, 3. So you're drawing a tic-tac-toe board with filler that creates structure underneath the skin and will help get rid of those deep lines. These areas are your nasolabial folds. If someone says this bothers you, the first place that you're going to look is the mid face, right? If they don't have enough volume in their mid face, you need to add volume there, and then you can go and do some dedicated at the nasolabial fold. Same with the marionette lines. Always kind of look at the mid face, and that will help a lot in the marionette lines as well. For the lips, quick anatomy recap, you have the Cupid's bow. That's that little area right in the center. You have the 2 peaks of the Cupid's bow and the trough of the Cupid's bow. Then you have the lateral oral commissures on either side. And on the upper lip, you have kind of 2 pillows. And then on the lower lip, you have 3, right? You're going to be filling all of those pillows. You never, not never, you very rarely fill that center pillow right in the upper lip. A lot of people have a lot of volume there, even someone who has small lips. So start with the 2 lateral ones and then the 3 bottom ones. Like I said, very rarely will you need to fill that top one. We taught you the line and fill method. The fencing technique, also called the Julie Horn technique, also called the Russian lip technique. But the fencing is where you go through the vermilion border all the way up to the wet to dry line. Aspirate, give a little dollop, and then pull straight down. And retrograde injections, those long fences, will give the lip height without giving it projection. So it's just a different technique. For the mid face, remember how you mark. Remember, always draw on your patient. It makes it super easy because you want to plan out where you're going to go. When I do lips, I draw on the patient's lips. I figure out where I want to do my marks, where I'm going to do my threads, draw on their lips. For the cheeks, you draw 3 lines. You go pupil, straight down, lateral canthus of the eye, straight down. Then from the tip of the ear to the tip of the nose, draw a line straight across. And then usually I'll do 1 dot at the apex of the cheek where you have the most projection, and I cross those lines. Then I go 1 centimeter lateral of that line that goes straight down. Remember that infraorbital artery is typically directly below that pupil. So we go 1 centimeter lateral of that just to help keep you safe. Straight to the bone, 90 degrees in. You're going to aspirate for 6 seconds, and you're going to put 0.2. Then you're going to go 1 centimeter over, and you're going to do 0.1. And then you're going to go on the other edge of that line, 0.1. Again, down to the bone. So 0.2, 0.1, 0.1 along the zygomatic arch. That is where you're putting all of this filler. So 0.2, 0.1, 0.1. Then you're going to do the other side, 0.2, 0.1, 0.1. You've now used 0.8 of a 1 ml syringe. So you have 0.2 left. That's when you can go in and look at any asymmetry they have, and you can go and you can add whatever you need to add. This is where that RH4 is really nice because RH4 has 1.2 mLs. So you get a little bit more bang for your buck. So it's really nice. I can go in and I can add an additional 0.2 into the patient's face. Sometimes I'll go right at the piriform. This is your piriform right here. If you can see that right there, that's your piriform. You go 90 degrees in, all the way in, tap the bone, aspirate 6 seconds, and add 0.1 right there. and it will kind of act as a fulcrum and help pop out a little bit of that nasolabial fold as well. So I'll do a lot of that with Restylane, or I'm sorry, with RH4, because I'll do 0.1, 0.1, and then the rest 0.2 in their cheeks. So, really nice. We didn't get a whole lot into this in training, but for chins, when you do start doing chins, the biggest thing that I want you to know for a chin, super easy to do, is you need to pay attention to male and female anatomy. So female anatomy, the chin does not go past the tip of the end of the nares. Where male anatomy, it goes further. It's at the end of the oral commissures. So the male's chin is wider than a female's. Okay, so just you need to have that in mind whenever you do start doing chins, and then you just go straight in all the way down to the bone, aspirate, and then you're going to do 0.1 or 0.2 depending on how much you're doing. And then you can kind of go in more superficially and hit it from the side as well. But when you start taking more filler classes and you start coming to more of our advanced trainings, then you can start practicing with chins. Tear troughs, always do tear troughs with cannula, at least initially, until you're really, really comfortable with doing them. Because with tear troughs, the most important thing to know is to not overfill them, because tear troughs overfilled look not great. The tear trough area is very it's a hydrophilic area. A lot of swelling, a lot of water is there. And so if you overfill it, all of the fillers are hydrophilic as well. So they'll tend to swell a lot, especially if you overfill it. So less is more in the tear trough area. But again, just fixing this kind of mid-face area will soften the tear troughs. Okay. Complications, you have obviously a vascular occlusion. You have two types of vascular occlusions. You have an interarterial vascular occlusion where the filler accidentally got into the artery. And then you have a compression vascular occlusion where the filler is sitting right next to an artery and it compresses the vessel. If you do have a compression VO, obviously a lot easier to resolve. You can just kind of flood the area. If you do have an interarterial VO, then you need to go and you need to cannulate that vessel and then flood that vessel to kind of move that filler downstream and dissolve it. Reminder, we do have 2 ultrasounds in the company, so we can do ultrasound guided dissolving filler for you if needed. We talked about delayed onset granulomas, and that's, remember around the biofilm that we had talked about, that's where when you are injecting, you accidentally inject some bacteria into the lips or into the face, and the body forms a biofilm around it, then forming kind of a tumor-like structure, not a cancerous tumor, but a tumor-like structure. It is self-limiting, but it can be pretty detrimental to patients. We always try to go in and start with antibiotics, steroids. We'll try to dissolve any residual filler. Worst case scenarios, the patient does have to have surgical intervention to get it out. Always remember, when you start injecting, bruises can look gnarly. Right? So remember this picture, you can have some pretty gnarly bruising. The biggest thing that you want to look for is going to be blanching. That is the cardinal sign of a vascular occlusion. And if you ever are concerned and you send me a picture, what are you always going to do to check capillary refill? You're going to do it at the same 2 times, right? I need to compare it to something. Don't just send it me when you be doing this or putting a Q-tip on it. That tells me nothing. I need to compare it to the other side. Okay, so press it down. You want to compress the vessel, and then assess it. Obviously, if you just have one spot that's just not turning, then that's obviously a vascular occlusion, and just you can go and start dissolving it immediately. This is our VO protocol. Talked about delayed onset granuloma and biofilm in the videos. Alrighty. It's a lot of information on filler recap, right? Yeah. I know I went pretty quickly. The reason why we do this again in this class, during the onboarding session though, is just so you can kind of get familiar with it again, because after probation, you have to attend 1 more filler training. And it can be that second filler training day. Then you are released to do filler. But I want to kind of reintroduce it to y'all, that when y'all do come and you do get checked on filler, you don't feel like it's been 3 months since you've heard any of this. So just to kind of recap it all. All right, any questions on filler at all so far?
I had a couple questions. I know you mentioned that when we start using filler, it's important for us to make sure that we're selecting the right product for the right location. Do you, and I know you went over that with us, but is there any like resources that you guys have once we start injecting that we can like reference to, just like a quick little refresh sort of thing?
Yep. So
Okay.
there's a graphic and it's on the main MFL page. And it is, we put it together. I kind of interviewed all of the really high producing injectors and asked them their filler go-tos, and it's called Filler Go-To. And so search for it. And if I will also try to pull it back up in the Facebook page so it kind of auto populates to the top again. And it's like lips, this is what people like. You know, cheeks, this is kind of what people like. And so you can just kind of pick one and be like, okay, this, like, I'm going to try this one and kind of live there for a little bit.
And then as far as, because I know I have somebody that wants cheek filler already. I did tell her that I can't do that at the moment, but that I would be able to soon. But she really has like really strong nasolabial folds, but I know she also is missing a lot of depth. Like she has a lot of atrophy here on her cheek. So I know that cheek filler would probably help her. But if we were to do cheek filler and then we see a little bit more missing, can we in the same visit do
100%.
both?
100%.
And it should usually be with the same product, correct?
I mean, you don't have, it doesn't necessarily have to be the same product. I like to say with the same family of products, if that makes sense, unless they've received everything independently of each other. But if I'm saying the same product generally, or the product line, I'm generally okay. If you're going to do her cheeks, choose RH4 and then do 0.1 and 0.1 at her pariform. And then if you need more, you can always do like a half syringe or something and do like a little tic-tac-toe board with the, you can do it like that, or you can also go with the cannula and kind of fill in the nasolabial as well. So that's what I would do.
Okay, thank you.
Yep. Any other questions on filler? Excellent. Okay, moving into MFL operations. Does anyone have any questions about how anything works within My Face Lady? Yep.
I actually just wanted a little recap on ordering products because I did offload my the remaining product I had since it was getting close to that time to somebody here in the Austin area. So I want to order more, but I just wanted to make sure if I order some and don't reconstitute, do I still have to use it within a few days or
1 year.
okay, that's what I thought. Okay, I just before I placed an order, I wanted
Yep, as long as so if it's unreconstituted, I think it actually might be 2 years. But it's whatever like the actual expiration date is. Now, the only time we would ever need it back is if it's like an emergency and someone's in your area and they're like, I have a patient, I can't get anything. Stephanie might go in and be like, hey, does anyone have any unopened product, you know, in your area that you can get it to her?
Okay, all right, that's what I thought. And then just ordering products, and then for the finesse appointments, we just have to do a visit in AR and document that process and then charge them the $12 appointment fee. Is that correct?
Correct. Yep. Yep.
Okay.
Exactly. All right.
Hey, and I have a question. I had a finesse appointment that I actually put on my schedule, clocked her in or checked her in, however. And then whenever we started taking pictures, she was like, oh, I wasn't real sure because she thought that she needed one of the eyebrows raised or whatever. And I was just sitting there looking at her like, I don't see it. It looks good to me, you know, whatever. And I started taking pictures and I showed her the picture and she goes, well, maybe I don't need it. And I sent it to Lauren. Lauren's like, I think it looks good. So she changed her mind after she was already checked in, and it doesn't let me go back and cancel it. So it's still on my schedule. Is that okay? Or
Yeah, I'll cancel it for you. What's your name?
It's Lynn Grimsley.
Did you actually create the appointment or she's just on your schedule?
No, I did the appointment.
Okay. Yeah.
Yeah. And I sent that to Brian, and I think he said, I didn't really understand his answer. I think he just said it was okay or something like that. But I was asking, like, do I take it off or do I leave it?
Yeah. What's her last name? One more time. I'm sorry.
Grimsley, Grimsley. I don't remember the exact date it was. Maybe last week sometime.
Where do you live?
Cleveland, Houston area.
You're in Houston. Okay. I had to make sure I
Yeah.
was in the right state.
Yeah.
And it's GRIMSLEY.
Yes, ma'am. And so in the future, don't check in until I know for sure they're gonna
It's
do
not a
it.
big-
'Cause
Yeah, you can always go back in and you can just delete the procedure. And that's what I'm trying to do, but it's not pulling up. What is her first name?
Lynn,
LYNN?
uh-huh. And I wrote a note in there that, she changed her mind or whatever in case it stayed on if it needed to stay in the chart or whatever, but I didn't know if I went in to sign charts that it's still going to be on there.
It might be, but there's a trash can button. I don't know what is going on. There's a trash can button. I'll just make a note and I'll do it. My AR is not wanting to connect.
Yeah. Okay. I couldn't get it earlier. I was trying to get on.
I think they said that AR updated, so we have to delete the app.
Oh,
and
maybe that's what's going on. Yeah, it's every now and then it does that. It's super annoying.
Oh, you have it delete the app and go back? And add
Sometimes
it
you
back?
just have to update it.
Okay.
And then I had a quick question regarding the process of going through the appointment and like finesse appointments. I'm pretty sure it was somewhere, I just can't remember for the life of me where. Is there somewhere that we can reference to, that way I don't have to bother Katie or you or say, hey, how do I create the process or the order of doing an appointment again? Because I have a few clients that or a few people that are interested in appointments, just so that it's fresh in my head and I can kind of review real quick. I just do I think we just have to do the like consents, sign them in, create the appointment for them, do consents, and take pictures and all of that, and then do the telemedicine visit, correct?
Yes. Are you saying just like the general, like how do you go through the whole appointment process?
Yes.
Yes. There's a graphic and there's also a video, and I will tag you in it.
Okay, perfect. Thank you.
Yep.
Just good for me to I like to like memorize those things.
Yeah. Appointment tag and video.
And that also covers finesse appointments, because I know the finesse appointment I had was pretty informal, but just finesse appointments, I don't know if we have to always create an appointment and then do the charging process, and if we need to do a telemedicine visit every time, or should that
So
be covered?
finesse, you don't. Finesse is, hey, they might have a spot guy or something like that, and that's already kind of covered. It's the enhancement where I need more, like you didn't. Yeah, finesse is like, you got a little bit of spot guy, let me give you a little finesse.
Okay.
Enhancement, it's like, you just need more.
Okay.
So you do not need to have a telemedicine for finesse.
Okay. And then I know I see in the group chat sometimes that people are posting dose change. That's usually when somebody, let's say, would possibly be a finesse appointment, and then we decide, oh no, it's going to be more.
Right.
Or what would constitute a dose change? That's what I wasn't too sure.
Yeah. So let's say you saw someone last month and they did 50 units of glabella. Okay.
Mhm.
And then this time they're like, oh, I think I want to do 50 units of glabella and I want to add my crow's feet. Okay. That's a dose change.
Okay, got it. Okay.
It's different than what they've done in the past.
Okay, I didn't know if that was that we were actively doing less or more of the same in the same spots. And I was like, oh, how do I go about determining like 2 instead of 2 units doing 1, or
Yeah. So I mean, if you're just going to go in and it's the exact same thing, like, oh yeah, we're just going to do the exact same thing we did last time, done. You don't have to do a tele. But if they're like, I think I need a little bit more, it's different. So that's what also would constitute a dose change.
Okay, got it. And that usually we would allow the nurse practitioner that's doing the telemedicine visit to decide that for us.
Yep.
Thank you.
Yep. Absolutely. All right. Okay. Moving on to AR questions. Any general questions do y'all have for aesthetic record? Besides that, sometimes you need to update it. Nope. Perfect. Moving on. All right. This week, this is your homework assignment. You're going to do an Instagram or Facebook Live /reel. Joanne, I know that you've already done a couple. They're super fun to do. Can be very informal. It's really kind of putting yourself out there to do it. It doesn't have to be some big production. It can just be you walk into your car, or, you know, you like just looking off in the distance, drinking your coffee, being like, thinking about the Botox patients I'm going to do later today. Something very, very informal. Again, I'm just getting you comfortable, getting yourself out there. You're also going to post a before and after of cheek filler. I already have the picture for you that you can post out there. And you say, you know, this is something that I can offer you, you know, in the future. And then you're also going to do one education post about how the face ages. This is something that you're going to develop on your own. You can just talk about how at the age of 35 that you start losing collagen in your face, and that the bones start to get more brittle and the fat pads start to separate and disintegrate. Obviously say them in nicer words than I'm saying right now, because what I'm saying sounds horrific, but say it in nicely, aesthetically pleasing words like spicy, right? But I want you to get used to doing education posts. Again, that's the purpose of that exercise. And then continue your social media following. I like the aesthetic _ injector, and then the injector Ken's is great as well. So continue following your social media following. I'm going to end my screen share.